Now, next topic is the injury to the birth canal. Maternal injuries following childbirth process are quite common and contribute significantly to the maternal morbidity and even to death. Prevention, early detection, and prompt and effective management not only minimize the morbidity but prevent many gynecological problems from developing later in the life. Now, the vulvar laceration of the vulval skin posteriorly and paraurethral tear on the inner aspect of the labium minora are common sites. Paraurethral tear may be associated with the breast hemorrhage and should be repaired by the interrupted catgut sutures, preferably after introduction of a rubber catheter into the bladder to prevent injury to the urethra. Now, the perineum, while minor injury is quite common, especially during the first birth, gross injury, third and fourth degree is invariably a result of mismanaged second stage of the labor. Overall risk is 1% of all the vaginal deliveries. Causes perineal injury result from overstretching, rapid stretching of the perineum, especially when the perineum is inelastic, usually the perineal scar, old perineal scar, elderly primigravida. Prevention, proper management of the second stage of the labor, taking care of the perineum when it is likely to be damaged is essential. The prevention of the perineal injury in normal delivery. Risk factor for the third degree perineal tear, big size baby greater than 3 or 3.5 kg, nulliparity, outlet contraction with a narrow pubic arch, shoulder dystocia, forceps delivery, scar in the perineum, perineuraphy, previous episiotomy, face to pubis delivery, midline episiotomy, precipitate labor. Classification of the obstetric anal sphincter injury according to the RCOG guidelines 2007. First degree injury is injury to the perineal canal. Secondary injury to the perineal involving perineal body but not involving the anal sphincter. Third degree injury to the perineum involving the anal sphincter complex, both external and the internal sphincters. It is divided into the A, B, C. A, less than 50% involvement of the external anal sphincter thickness. B is the greater than 50% of the external sphincter thickness tone, both ES and IS tone. Fourth degree injury to the perineum involving the anal sphincter complex and the anal epithelium. This is a pictorial presentation for the degrees for the perineal tear. Vagina, isolated vaginal tears or the laceration without involvement of the perineum or the cervix are common. They are usually seen following instrumental or the manipulative deliveries. In such cases, the tears are extensive and often associated with the breast hemorrhage. Treatment tears associated with the breast hemorrhage requires the exploration under general anesthesia with the good light. Tears are repaired by the interrupted or continuous suture using chromic Gatkit 0. In case of the extensive laceration, in addition to the suture, hemostasis may be achieved by the intravaginal plugging by roller gauze soaked with glycerin and the acroflavin. The plug should be removed after the 24 hours. Selective arterial embolization may also be done if the bleeding persists. Colporexis, rupture of the vault of the vagina is called the colporexis. It may be primary where only the vault is involved, or secondary when associated with the cervical tear. It's said to be complete when the peritoneum is opened up. Posterior fornix usually ruptures, however, cervical tear is usually associated with the tear of the later fornix. Treatment if the tear is limited to the wall close to the cervix, the repair is done from below. If, however, the cervical tear extends high into the upper segment or the major branches of the uterine vessels are damaged, laparotomy is to be done simultaneously with resuscitative measure. Evacuation of the hematoma and arterial ligation may be needed sometimes. Cervix, minor degree of the cervical tear is invisible during the first delivery and requires no treatment. Extensive cervical tear is rare. It is the commonest cause of the traumatic postpartum hemorrhage. Left lateral tear is the commonest. Causes are the iatrogenic attempted forceps delivery or the breech restriction through incomplete dilated cervix. Rigid cervix, this may be congenital or more common following the scar from the previous operation of the cervix, like amputation, conization, or the presence of the lesion like carcinoma of the cervix. Strong uterine contraction as in precipitated labor, extremely vascular cervix as in placenta previa. Detachment of the cervix may be the annula which involve the entire circumference of the cervix. This occurs following prolonged labor in primary cervical dystocia. It may, however, involve only the anterior lip when it is nipped between the head and the symphysis pubis in association with the sacral os. In both varieties, the bleeding is minimal and healing occurs through the epithelialization. Diagnosis: excessive vaginal bleeding immediately following delivery in presence of hard and the contracted uterus raises the suspicion of a traumatic bleeding. Exploration of the uterovaginal canal under the good light not only confirms the diagnosis but also helps to know the extent of the tear. Dangerous early deep cervical tear involving the major vessel lead to the severe PPI, broad ligament hematoma, pelvic cellulitis, thrombophlebitis. Late complications or late dangers are the ectropy and cervical incomplete and the mid-trimester abortion. Treatment: only deep cervical tear associated with the bleeding should be repaired soon after the delivery of the placenta. Repair should be done under general anesthesia and lithotomy position with a good light and with good assistant. Prerequisites are the sim, posterior vaginal speculum, vaginal wall retractor, at least 2 or 3 sponge holding forceps and an assistant. The anterior and the posterior margins of the torn cervix are grasped by the sponge holding forceps. Instead of giving traction to the cervix, it is better to push down the fundus gently by the assistant. This makes the tear more accessible for the effective suturing. Apex is to be identified first, and the first vertical metal suture is placed just above the apex using the vical or the chromic actin number 0, taking whole thickness of the cervix. The bleeding stop immediately. The rest of the tear is repaired by the similar metal suture. Metal suture is properly as it prevents rolling of the in of the edges. A helpful guide for the proper exposure in such a case is to start suture at the proximal end and using the sutures for the traction. More distal tear area is exposed until the apex is in view and is repaired. The cervical tear extending to the lower segment or the wall with the broad ligament hematoma are managed as outlined in the ruptured uterus. This is a method, this is a picture presentation how to hold the cervix with the two sponge holding forceps. And the suture is given, vertical metal sutures are given. Now the pelvic hematoma. Definition is the collection of the blood anywhere in the area between the pelvic peritoneum and the perineal is known as the pelvic hematoma. Most common sites are the infralevator hematoma or the supralevator hematoma. Infrahematoma, the most common one is the vulval hematoma. Etiology: improper hemostasis during repair of the vagina, the parental or episiotomy one. Failure to take precaution while suturing the apex of the tear. Failure to obliterate the dead space while suturing the vaginal walls, rupture of the paravaginal venous plexus either spontaneously or following instrumental delivery. Symptoms may persistent severe pain on the perineal region. There may be rectal tenesmus or bearing down upwards when extension occurs to the issue fossa. There may be retention of the urine. Signs: variable signs of the shock may be evident. Local examination of tense swelling at the vulva, which become dusky and purple in color and tender to touch. Treatment: small hematoma less than 5 cm may be treated conservatively with the cold compresses. Larger hematoma should be explored in the operation theater under general anesthesia. Simultaneous necessitative measures are to be taken. The blood clots are to be scooped out and the bleeding points are to be secured. Usually a generalized oozing surface is visible. The dead space is to be obliterated by the deep metal suture, and the closed suction drain may be kept in the place for 24 hours. A Foley's catheter is inserted till the tissue edema subsides. The prophylactic antibiotic is to be administered. This is a picture presentation for the vulval hematoma following the spontaneous delivery. Supralevator hematoma causes extension of the cervical laceration of the primary corporate axis of the wall rupture, lower uterine segment rupture, spontaneous rupture of the paravaginal venous plexus adjacent to the wall. Supralevator hematoma. Rupture of the uterus. Definition: disruption in the continuity of the wall of all the uterine layer, that is endometrium, myometrium, serosa, any time beyond the 28 weeks of pregnancy is called the rupture of the uterus. Small rupture of the wall of the uterus is in early month is called the perforation, either instrumental or perforating etchment. Rupture of the rudimentary pregnant horn has got a spatial clinical entity and is grouped in ectopic pregnancy. Incidence is 1 in 2000 or 1 in 200 deliveries. During the past 2 decades, the prevalence has been found to be almost static. Whereas improved obstetric care reduces the rupture from the obstetric labor, but there has been increased prevalence of scar rupture following increased incidence of cesarean section over the years. This is a pictorial presentation showing the rupture uterus. During pregnancy, spontaneous intact uterus, scarred uterus. If the enters multiple paras, congenital malformation of the uterus, abruption placenta, perforating mole, placenta percreta, scarred uterus, previous cesarean section, hysterectomy, scar, previous manual removal, or the DNC. Nitrogenic traumatic external cephalic version, fall, blow, use of prostaglandin oxytocin. During labor, spontaneous intact uterus, non-obstetric grand multipara congenital malformation of the uterus, obstetric following obstetric labor, iatrogenic traumatic vaginal instrument delivery, internal version, manual removal of the placenta, oxytocin, use of oxytocin and the prostaglandin. Dehiscence and the scar, which is scar dehiscence, disruption of the part of the scar and not the entire length. Fetal membranes remain intact, bleeding is almost nil or minimal. Scar rupture, disruption of the entire length of the scar, complete suppression of all the uterine layer, including the serosa, rupture of the membrane, varying degree of bleeding from the margins or its extension. Uterine cavity and the perineal cavity become continuous. This is a presentation of the lower segment uterine scar, arrow represented. Visceral injury. Bladder causes obstetric injury to the bladder may be due to the traumatic instrumental vaginal delivery as a destructive operations or the forceps delivery, especially with the Keelan instrument, Keelan forceps. Abdominal operations such as hysterectomy or rupture of the uterus or the cesarean section, sloughing fistula. It results from the prolonged compression effect of the bladder between the head and the symphysis. Pubis is obstructed liver. Diagnosis with traumatic urine tribbles out from soon following the operative delivery, blood stain urine following season section hysterectomy suggestive of the bladder injury. Margins are clean cut with oozing surfaces, sloughing fistula history of prolonged liver, dribbling of urine occurs after wearing interval following delivery. Margins devitalized and the necrosis missing of the chunk of tissue. Now, the management traumatic fistula immediate repair is preferable if the local tissues are healthy. In unfavorable conditions, salvaging catheter is introduced and to be kept for 10 to 14 days or even longer. Urinary antiseptics are prescribed. In favorable condition, there may be spontaneous closure of the fistula if it fails typically to be done after the 3 months. Sloughing fistula should not be attempted as the conditions are not ideal. Instead, a self-retaining catheter is placed as outlined above and repair to be done after the 3 months. Rectal injury other than involved along with the complete perineal tear is rare in obstetrics, and this is because the middle third of the rectum is protected by the curve of the sacrum hollow and the upper third is protected by the peritoneal lining. Prolonged compression of the rectum by the head and the middle pelvic cavity with a flat sacrum predisposes to ischemic necrosis of the anterectal wall and result in the rectovaginal fistula. The repair in such cases should be postponed for at least 3 months. Urethral injury may be traumatic resulting from the instrumental delivery or during puberty. Maybe ischemic sloughing or the mechanism of which similar to that of the bladder necrosis. The principle of the matter is similar to those of the bladder injury. Thank you.